Okay, good afternoon, everyone. Thank you for joining us for today's webinar. My name is Doreen. I'm with the New England QIN-QIO. Before we get started, I'll review a few housekeeping items. This call will be recorded for training purposes. The presentation is available on the event webpage. The link has been posted in chat. Excuse me, we're getting background conversation. Can you mute your phone, please? Phone lines will be on mute for the duration of the presentation. Please don't place this on hold. If you find that the presentation is a little cut off, use the plus or minus icon on the left of the presentation window to adjust your screen accordingly. You can enter questions in chat, but remember to send it to all participants, or you can press #6 or your mute button to unmute your line and ask a question over the phone. At this time, I will mute all lines.
The leader has muted your line. To unmute your line, press #6.
Okay, all lines are muted, and I'll now pass this over to Francis Kinsey with the New England QIN-QIO to introduce our speaker, Dr. Joe Toscano.
Thank you, Doreen. Good afternoon, everyone, and thank you for joining us. Before I introduce the speaker, I'd like to thank you all for, again, joining us and to welcome you to part 2 of our two-part series, which is was put together in collaboration with the Urgent Care Association of America, now known as the Urgent Care Association. This is part of the objective for this collaboration is to get QIN-QIOs taking part in this webinar, as well as the Urgent Care Association, Urgent Care centers across the nation to connect and provide quality care to all beneficiaries as well. So thank you all again for joining us. And just some quick housekeeping notes for pharmacists seeking APPE credit, and also for UCA, CUCM participants seeking CME certificates. Please make sure to complete the evaluation within the next 2 days and give us about 2 to 3 weeks to process your credits and certificates. Okay, now to introduce the speaker. Dr. Joseph Toscano received his medical degree from Duke University School of Medicine in 1989 and trained in internal medicine at the Naval Hospital in San Diego. He has worked in the areas of emergency medicine and urgent care for over 20 years. He has been an attending emergency physician at San Ramon Regional Medical Center in San Ramon, California since 1999, and he is currently chief of the department. Dr. Toscano has worked in urgent care since 2005 and was previously a partner and corporate medical director for Pinnacle Medical Group, which operated 5 urgent care clinics in California and Arizona. In addition to caring for patients, he is a senior research editor for the Emergency Medicine Practice, a monthly evidence-based emergency medicine CME publication. He's also a member of the editorial board for the following journals: Emergency Medicine and the Journal of Urgent Care Medicine. He also develops and reviews continuing medical education material in urgent care and emergency medicine for a variety of other publications and organizations. He's been an active member of the Urgent Care Association of America, now again Urgent Care Association, since 2005. He has presented clinical topics at many educational conferences and is currently the clinical content coordinator for UCA. He is a founding board member of the Urgent Care College of the College of Urgent Care Medicine, with the board of certification in urgent care medicine under ABPS. Dr. Toscano, your audience.
Thank you. Thanks for that introduction, Francis. Good morning, everyone. Going here.
Joe, can you hold on for a minute whilst we mute everyone again?
Yeah, Joe, I'm going to have to remute everybody.
Okay.
The leader has unmuted your line. The leader has muted your line. To unmute your line, press pound 6.
Okay, so you should be all set.
Okay. Can everybody hear me? Can everybody hear me?
Yes.
Okay, great. So I need to make a quick disclosure because some people, UCA members, will be able to get CME for this presentation. I do have one commercial event that I did a little over a year ago where I helped some of the marketing folks at Kaiser understand the urgent care environment in terms of what clinicians do on a day-to-day basis. It's not related to what we're talking about today, but it is a disclosure. And there will be no discussion of any off-label or experimental devices in this presentation. We're going to cover a fair amount of stuff in the next 40 minutes or so. By the end of this, I hope everybody will understand the bad effects of inappropriate prescribing and how it actually hinders our ability to take care of patients. This applies to urgent care, but also other urgent care settings, primary care offices, and EDs. The last month's webinar, I talked a little more in depth about the clinical resources that are available to us to help guide us in terms of making proper decisions about when to treat and which antibiotic to use in a variety of the most common infections that we see in acute care and urgent care. I'm just going to touch on that again so that this one presentation could stand alone by itself, but that was discussed a lot more in depth last month. There are a variety of techniques and tools that are available that can help us move in the proper direction in this antibiotic stewardship effort. I will review those. Mostly what I'm going to talk about today is really the how that we can affect this change. How are we going to get patients to think differently about antibiotics, and then also how are we going to change ourselves and change patients' expectations, because I think most of us feel that's the big stumbling block with this. We're in a situation where patients are used to getting antibiotics in a lot of situations where they probably shouldn't, and we need to turn the tide there. I'll start off, kind of cutting to the chase and maybe explaining the why before I explain the how. The why, and I think everybody agrees with all of this, is that antibiotic resistance is rising. Even when antibiotics are used appropriately, it leads to increases in resistance just because of evolutionary pressures that there are on bacteria and organisms. This antibiotic resistance makes it harder to take care of patients, and it's directly related to our prescribing, both appropriate prescribing and inappropriate prescribing. In urgent care, a lot of patients are seen for acute infections, so antibiotics account for a large amount of prescriptions prescribed in acute care and in urgent care. And though there's some evidence that things are improving, this overprescription and inappropriate prescribing is still too common. Some statistics on that coming up. And it's not the case that we don't know what to do in these situations. There are really good evidence-based guidelines to tell us how to treat these infections properly and to affect the change that we need. There are a variety of interventions that have been proven to help both affect change in physicians and patients, and then also to help preserve patient satisfaction in these situations. I kind of talked about this a little bit last time, and if you're prescribing antibiotics for any of these top three reasons, because the samples are going to expire in the office, or because the drug requires lunch, or because your practice makes money on dispensing, the rest of this is probably not going to make much sense to you. But it is the case that it's been shown that things like free lunch and free pens do affect our prescribing, so it's important for us to be conscious of that and be careful about it. Most of us will tend to retreat to these more classic excuses at the bottom when we're confronted with information that we're not doing the right thing. That's how I was trained. I want my patient to have the best outcomes. I need to do the same thing as people around me are doing. There's just not enough time. It's quicker to prescribe an antibiotic than it is to explain. And then this whole idea about the fact that patients will not be satisfied unless they get an antibiotic. And there are counters to each of these. I mean, none of us finished our training just yesterday. Our training is basically out of date soon after we begin practice. We need to continue to learn new and appropriate approaches to taking care of patients. It is the case actually that outcomes are worse when patients are prescribed antibiotics inappropriately. It is the case that there's a standard of care, and the standard of care now does involve overprescription, but what we need to do is get our colleagues and everybody around us to begin to do the right thing. It is the case that it's probably quicker to write a prescription than it is to explain to the patient what's going on and why they might not be doing in this situation. But we need to take that time. It's worth it to take that time to have them understand it. And then finally, there are ways to keep patients satisfied without giving them an antibiotic, and I will review this.
Excuse me, Joe. I have to interrupt for a minute. Excuse me, but we're getting some background conversation. Can you mute your line by pressing *6? Thank you. Okay, Joe, go ahead.
Okay. And as I mentioned, even appropriate prescribing has a downside, but inappropriate prescribing really magnifies the bad effects. Inappropriate prescribing leads to a lot more this sort of badness, cough, poor outcomes, allergic reactions to antibiotics that patients wouldn't have gotten if they didn't get the inappropriate antibiotic. GI side effects really common, including the worst one, Clostridial yeast. Tendinopathies and QT prolongation with fluoroquinolones, QT prolongation with macrolides as well. Patients are on more and more medications these days, and so there's risk of interaction that we don't even really need to consider when an antibiotic is not necessary. And then finally, there's some new information. It's kind of not causal link hasn't been proven, but in terms of observational studies, that patients who take more antibiotics actually have a higher risk of type 2 diabetes in the future, and it's actually postulated that gut bacteria has a role in that, and the alteration of gut bacteria by taking antibiotics repeatedly. So kind of an interesting idea. We'll see if it comes to be proven more definitively. The cost of rising antimicrobial resistance is high. We talked about higher costs in general. This is all CDC data here. Health outcomes are poorer when patients are given antibiotics inappropriately, and then when they have those side effects, they are subjected to more toxic treatments as a result. About 23,000 patients a day die as a result of antibiotic resistance, and then costs of about $30 billion a year. Adverse drug events related to antibiotics are a common reason for presentation of both children and adults to the ED. And then again, any of these percentages would be zero in the case where an inappropriate antibiotic were not prescribed. So there's a few more facets to this, like antibiotic use in raising animals for food, but there's still a lot of overuse of antibiotics in the medical community, and this includes both prescribing antibiotics when they're not needed and prescribing an antibiotic of a broad spectrum when one of a narrow spectrum would work just fine. It's estimated, and it depends on exactly how you look at it, but somewhere between 30 to up to 50% of antibiotics may be inappropriate in one way or another, either unneeded or of the wrong spectrum or too long of a duration. And all of those have, again, unnecessary bad effects. On the flip side of that, however, we can improve the situation by modifying our prescribing. Antibiotic use is the most important, potentially changeable driver of antibiotic resistance. And as an example of that, it's been estimated that if we were to just increase inappropriate prescribing by 10%, we would have almost double of that in terms of a reduction in C. diff infections. Take heart. There is a way out of this. There are actually several ways. And in thinking about how we can change things, there's several components to this. Again, the subject of the lecture last month, or the presentation last month, was to know when not to prescribe antibiotics and when to prescribe them and what to prescribe in those situations, keeping the spectrum appropriate for the infection. And that's something as clinicians we need to constantly stay updated about. talk a little bit about that. Really, the way we're going to affect change is to have patients expect different things than they have more recently. We need to educate them and engage them in this. In terms of involving our colleagues, and we'll talk a little bit about that. Sometimes it's harder to change behavior in other people than it is in ourselves, but it's going to be important for us to all do this together. I think it's going to be really important for us to be patient with ourselves, be patient with colleagues and patients. Change is hard in general, and this is going to be probably a potentially difficult one, so it's not going to change overnight. It is important to know what you're going to do. You can't just start your day and say, well, I'm going to try to do something different than I ever have before. You have to have some strategies and even some tools. That's probably an overused word, but kind of some tricks and implements that are going to help us make this change. And it's important to be consistent. A small change on a consistent basis that's gradually increased is probably going to be more sustainable than just a drastic change that is uncomfortable. It's going to be important to stay committed to this. This problem is not going to go away. These little changes that we make that become bigger changes over time in a positive direction are going to have to be the new norm. And then I think finally, we hold the power of the prescription. It's the one thing we can do that a lot of other people in healthcare can't. A nurse or medical assistant or folks in other roles. But we really need to think of ourselves more as an educator and a diagnostician rather than just a prescriber. Yes, sometimes we're going to have to prescribe something, but in just about every case, we need to make a good diagnosis and we need to educate patients about what's going on. But when we are prescribers, we need to be sure that we get this right. The true foundation of antibiotic stewardship is that not only not prescribing when patients don't need them, but when we do prescribe, making sure we've made the proper diagnosis, that we know the proper antibiotic spectrum for that diagnosis, that we get the dosage right, and we get the duration right. Here are, I think these are also available elsewhere. There's some other links that the QIO is going to make available, but these are some convenient and I think really some of these are densely informative. If you go to the ID Society Practice Guidelines, you can download for free the papers that talk about diagnosing and treating these infections. Tons of information on the CDC website under their Get Smart campaign that they're currently rebranding, but it's still called Get Smart. And then the California Aware Foundation, which is the alliance working for antibiotic resistance education, has a lot of materials for clinicians and patients, and you can access that at the web link at the top here. This is an example of a clinician tool. This is the adult compendium that describes properly diagnosing and what the treatments are. It's a blurry when I blew it up, and again, it's just an example rather than having to learn right from this one slide. This is the backside of the pediatric guideline, which runs through the common infections, talks about when patients should be treated and what the appropriate antibiotics are. I think, in my opinion, having looked at a bunch of these and used these in my own practice, I think the one that is probably the single best one is produced by the New York State Department of Health. You can download it directly at the website, the web address, the URL at the top. You can print it on any stock paper that you want. It ends up, after folding it 3 times, being about 4.5 by 6.5 inches. It fits into a white coat pocket. The other compendia are a little bit larger. And actually, Mary Beth Wenger, who works for the New York Department of Health, if you want, can send you one or multiple of these that are laminated. And they last actually for as long as the recommendations do. These are updated periodically, and my laminated one is still in really good shape. So these are put out every year or two, even when the recommendations don't change. but it is very useful to know what the state of the art is in terms of prescribing for the common infections we see in urgent care and in acute care in general. So what's so good about a prescription anyway? It's actually, a prescription is powerful in many ways, and I think it's important for us to understand that, and we can't just take our prescribing for granted. From the patient side, they're actually getting something when they come for a visit. They're leaving with either a piece of paper or knowing that they're going to go to a pharmacy and be able to pick up something as a result of the interaction with a clinician. It leads to a validation of illness. They feel bad, and it's something that kind of puts a stamp of approval on it. Patients also get a sense of being taken seriously when they get a prescription. And also this impression that, oh, that clinician is nicer than the one that wouldn't give me what I wanted. And, something that isn't talked about too much, but probably is the case, we don't have placebos that we can prescribe for patients. It's not really ethical to do that, at least in terms of something like an antibiotic. Maybe the symptomatic care agents are having a placebo effect. But from the patient side, it is one of the things that reinforces a patient wanting a prescription. And I mean, you have to think about the psychology of this for them. In the current pattern where patients are getting prescriptions that they don't need, in their mind, they're saying, I was sick with something, I went to see a clinician, I was diagnosed with a problem, I got a prescription, and I got better. Therefore, the next time that happens, the same thing should happen again. And that's what we really need to change. And there's a way, actually, to give the patient something, to validate their interest, to take them seriously, to appear to be nice, with some of the efforts that I'm going to describe. On the clinician side, and I'm going to present some data that shows this is just about as much about us as it is about the patients. We really feel good when we prescribe an antibiotic, I think, because we feel like we're doing something, we're meeting patients' expectations, we hold the power of the prescription, and we are wielding that power in the patient-clinician interaction when we prescribe something. So, again, understanding that is important because it's what motivates us and what has gotten us to this current state. So, what's the data? Is there data that says that when patients get an antibiotic that they're more satisfied? And there are many studies about this. I put up some of the ones. You can look these up if you want, that are kind of the most poignant ones. And the interesting pattern about this that I noticed as I was preparing was that the older study showed there was no relationship between patient satisfaction and an antibiotic prescription. And all the data that's beginning to show that patient satisfaction is linked to it is more recent studies. The ONG study here, which was the kind of most recent one, about 11 years ago, 2007, actually a fair amount of antibiotics were prescribed to patients, probably inappropriately. 68% of patients got them for bronchitis. 10% of patients with URIs got antibiotics, but they found that patient satisfaction was truly related to a better understanding of their illness and wasn't correlated to the prescription. Tide started to turn maybe about 10 years ago, and the Stearns study, actually Ralph Gonzalez, who's in the 2001 study here, the researcher at UCSF, he was the lead author of the 2001 paper, and he was actually one of the senior faculty, but not the lead author on the Stearns article. And I think it was probably bewildering for Ralph that all of a sudden things were changing. The conclusion of the Stearns study was really just that more research needed to be done on how to continue to maintain patient satisfaction and reduce antibiotic prescriptions at the same time. The article had really, it was more a description of the problem rather than giving us any solutions. The Martinez et al. Should be 2018 as well. It was just published a research letter in November, just last month. And at the Cleveland Clinic, and it was a little bit depressing. What they found was that to be in the upper 5% of patient satisfaction, a clinician they found a correlation where the clinicians were prescribing antibiotics over 75% of the time. But they also found that when a non-antibiotic prescription was given, patient satisfaction was higher as well versus the patient getting absolutely nothing in terms of a prescription. This was a telemedicine study, so it's a little bit removed from situations where you actually have a patient sitting in front of you, so there may be a little bit of difference there. But somewhat depressing that maybe there is some link between patients getting prescriptions and their satisfaction. But this could be somewhat of a self-fulfilling prophecy, and by that I mean that the clinician expectation that's woven into this, and these were two very interesting studies, relatively recent. And in the McKay article, what they found was that the clinician could not really tell whether a patient wanted antibiotics or not. They thought they knew, and that was what motivated them to prescribe. But when they actually asked the patients, there was very little correlation between what the clinician thought the patient wanted and what the patient actually wanted. And what they found was when an antibiotic was prescribed, it was actually more closely correlated with the clinician's perception of what the patient wanted rather than what the patient actually wanted. So, kind of an interesting finding. The Conan article, this I think is actually very instructive for us. They actually characterized patients in terms of whether they expected an antibiotic, whether they hoped for an antibiotic, or whether they frankly asked for an antibiotic. And there was overlap between those groups. You would have a patient who both expected and hoped for an antibiotic. Or you might have a patient that didn't expect an antibiotic, but did hope for an antibiotic. Or then somebody may actually have expected it, hoped for it, and asked for it. What they found was that clinicians, it was about a 50-50 chance in terms of whether clinicians could actually tell whether a patient expected an antibiotic or hoped for an antibiotic. They could obviously tell whether the patient asked for an antibiotic. And again, similar to the study by McKay, more so than what the patient wanted, it was the clinician perception that drove the prescribing. Overall patient satisfaction was high, which was good. The lowest group actually was a patient that hoped for an antibiotic but did not receive it. And I think that's where we need to kind of think about things. I think the idea of a patient expecting an antibiotic is that they had received one in the past, and so they expected the same thing to happen again. Hope for is a little bit deeper in terms of what the patient hopes to get from that visit. And I think the ones who are the least satisfied are when they truly hoped for it because they thought it was going to make them better and they didn't receive it. So in general, kind of turning this around, and I think, again, we need to look at ourselves in terms of what expectations need to be understood and changed. And it's about as much about us as it is about our patients. This, I think, also is the reason why making a public commitment to change is important. You can say that you're going to do this, but part of the CDC toolkit and the CUCM toolkit, which I'll talk about in a bit, is making a public statement, having a letter that you post on the wall in front of your patients that you are committed to antibiotic stewardship. It's showing that we care about our patients and that we care about the change that's going to happen in ourselves. So government and non-governmental organizations are doing a lot of things to kind of help the effort. And some of you may be seeing programs and processes for change coming down from your administrators or your medical directors. But what do we have? What do we have under our control in terms of making changes in terms of antibiotic prescribing? It's physical, number one. It's what we do. You walk in the door, you close the room. You walk in the room, you close the door, and you start to talk to the patient. And I've been doing this for a while, and what I find is, as I'm talking to the patient, getting a history about what their symptoms are, to begin explaining that, wow, that sounds like this is a virus. It's good that there's no signs, at least from your history, that there's a bacterial infection. So let's go ahead and follow up with your exam. And as you're examining the patient, it takes absolutely no time as you're looking in their ears to say, your ears look fine. There's no infection. To look in the throat and say, wow, your throat looks a little bit irritated, but it doesn't look bad. Listen to the patient's lungs and explain that the lungs sound clear, that there's no evidence of pneumonia. A history and exam, again, is what we do, and it's actually an amazing tool in terms of influencing the patient, rather than just taking a quick history and doing a physical in silence. Again, explain and reinforce the idea that although the patient may feel badly, the exam is normal and doesn't support a bacterial diagnosis. There are a variety of patient education materials. I'll show some examples during cold and flu season or really all year round. It's nice to have these available. Patients can see them if they're posted on the wall. On the counter in patient care rooms, you can have these in little stacks or folders to be able to give them to patients. And again, all of these reinforce the idea that antibiotics are not needed in most cases where patients have respiratory tract infections. Again, harkening back to the Conan article, if you're seeing that furrowed brow and the patient's not really kind of understanding that they're not going to get an antibiotic, just ask them frankly about, well, what is your expectation? What's been your prior experience when you felt like this? Did you hope to get an antibiotic? Sometimes you've got to take an extra minute or so to explore that if the momentum is not moving in the direction that you hope it to be. I think one of the highest impact areas is using objective tests. There's actually a recommendation to use rapid strep test, or some type of objective test before prescribing an antibiotic to a patient with a throat infection to confirm that it is, not beta hemolytic group A strep prior to prescribing. And what I find is patients don't argue with this. I could tell them the data and the Centaur score and say, well, you probably don't have strep. But when you do the test and it comes back negative, this is like God's gift to urgent care doctors, rapid strep test. And we should be using them in our diagnosis, and they can actually really help reinforce to a patient the idea that they don't need an antibiotic. Influenza testing, similarly. When a patient is diagnosed with influenza, unless they have a complicated bacterial infection, you can discuss using antivirals with them, but there's really no need for antibiotics. And it's actually been shown that utilization of influenza tests appropriately does decrease antibiotic prescribing. Once you have a diagnosis, you and the patient can feel comfortable addressing that diagnosis and not having them kind of make up another one like bronchitis or sinusitis to justify an antibiotic prescription. The flip side of this, though, is that these tests need to be used responsibly. If everybody who walks in the door gets a rapid strep and an influenza test, there will be false positives. And the more often this is done indiscriminately, the more often you're going to get false positive tests and end up treating patients who don't need to be treated. So, the best process to do a history and an exam and decide how those tests are going to help you make the proper decision and then do the test at that point. A couple other tests on the horizon, C-reactive protein and procalcitonin. About a year or so ago, some papers were published about how the use of those tests does result in better diagnoses. Kind of typically when the tests are normal, the chance of a bacterial diagnosis is very low. Kind of a shotgun approach. Patient comes in with symptoms and you get a CRP or procalcitonin. And when it's normal, you feel good. There's a general recommendation from lab experts to not really begin to use these tests until we have a little more data on it. And certainly don't use it unless you kind of indiscriminately again. But when you have a sort of an evidence-based protocol for their use, not every patient walking in the door getting this test, if you're going to get false positives and end up doing other tests because the test's not negative. But these may help us in the future. I think I do find in my own practice that, having an objective test in addition to history and an exam that excludes a bacterial diagnosis really does help a patient accept that a little bit more readily. And then certainly if the test is positive and the pretest probability is high enough, then you've made a definitive diagnosis and can feel comfortable with that as well. I think one of the things that we need to do a better job on, and that makes total sense, is that when in situations where we're prescribing an antibiotic when it's actually needed, we need to tell patients that there's potential harms. We need to discuss actually the side effects of anything we prescribe, with stomach upset and GI bleeding, with NSAIDs, another commonly prescribed urgent care medicine. But patients need to understand that even when the antibiotic is necessary, that there's harms to it, rising antibiotic resistance, and even personal harms that can occur, like diarrhea and those sorts of things. Studies have shown that making sure the patients know that they can easily get follow-up, either with a phone call or to easily come back and maybe get an antibiotic prescription a day or two or three later if they're not feeling well. That can be a tool to use to help a patient accept not getting an antibiotic at that initial visit. I don't really like the term scripting, but what I find is, having done this again, caring about antibiotic stewardship and explaining this to patients, I have about 3 or 4 things that I'll say, and I'll kind of say them sort of the same way when patients have that furrowed brow. When I say these things, they tend to relax a little bit and be a little bit more accepting. And then I think another high-impact strategy, a high-impact tool that we have, and I'll go into more detail about this, is this concept of a safety net prescription or a backup prescription or a delayed prescription. And, the semantics of this vary, but basically you are giving the patient access to a prescription that they're not going to take right away. And you can post-date the prescription. You can, what I find myself doing is maybe electronically transmitting a prescription for an inhaler for a patient who has wheezing and bronchitis and non-asthmatic, and then writing the antibiotic prescription on a piece of paper that the patient would have to fill at a later time rather than electronically sending it and having the antibiotic sitting at the pharmacy. And again, the idea of a safety net prescription is not to prescribe more antibiotics and do them all as a safety net, but as you're trying to change your prescribing practice and as you're using some of these other tools and the scripting and those sorts of things, and you're getting to the point where you really feel like you're not going to be able to not prescribe an antibiotic, you can use this idea that telling the patient to take it 2 or 3 days into the future can be part of a transitional plan for patients and for us in terms of changing the tide here. There probably is about a 15% reduction in prescribing with this, and actually there was a study that showed, I referenced it at the end slide, people by Little, and it was done in the United Kingdom, but they had almost 900 patients with a variety of respiratory tract infections. Sinusitis, bronchitis were most common, and they actually found that there was no difference in clinical outcomes when they had patients who were either given an antibiotic immediately or on a delayed basis, and they found that of the patients who were given an antibiotic on a delayed basis, about 40% of them never took it. So that was a 40% reduction in antibiotic use with delayed prescribing in that situation. And frankly, there's evidence that even when we prescribe for patients and tell them they should take something, that maybe up to 20% of them don't fill a prescription. By delaying it, that we call non-compliance. In this case, we want the patient to be non-compliant, but using that strategy would be helpful. Explaining, again, I'm just going to review here, but in terms of educating patients, some patients are very accepting. You do your history, your exam, and an objective test, and you tell them that they don't need an antibiotic. If you sense that they're not going to be happy with that, or if they tell you they're not happy with that, begin to tell them these sorts of things. Explain that there's harms to antibiotics, and that in some cases they can actually exceed any benefit. And if the antibiotic prescription is not necessary, there is going to be no benefit, although the patient is going to have its potential harms. And again, when we prescribe an antibiotic that is needed, we use it to explain side effects to patients so that the next time they come back, they will understand that downside even if they didn't experience it with the antibiotic in the first place. What I find that this is a fairly effective intervention to tell patients, again, their experience and their expectation may be that they've always gotten an antibiotic, but explain to them that this is new science and that it's expert guidance that's telling us to not do this anymore. About a year or so ago, there was a story of a couple of patients who actually died from these superbugs that are being created by rising antibiotic resistance, and I was able to actually tell patients, did you see that story in the news about the patient that died from that resistant bacteria? This is what we're trying to decrease by not giving antibiotics when they're not necessary. I do think it's really important, in those papers where they showed a relationship between patient satisfaction and antibiotic prescription, the comparison was they were getting a prescription or they were getting nothing. And that's, I think, where that contrast comes in. What we need to do is not just tell patients they don't need the antibiotic, but we need to make some positive treatment recommendations. Now, unfortunately, there's not a lot of good data to show that anything really helps. But discussing symptomatic treatment like fluids and acetaminophen and NSAIDs is an example of one of those positive treatment recommendations. These things will make you feel better. Taking ibuprofen and drinking plenty of fluids will help you feel better while you're getting over this. Two things that I've found that are helpful. I think, acetaminophen is a good medicine for aches and fever. And if a person has a headache and takes a couple of those and the headache goes away, perfect. When a person's ill, they're going to have those symptoms on an ongoing basis. So taking something like acetaminophen every 4 to 6 hours sometimes can be a drag. There are long-acting formulations of acetaminophen. They are marketed as arthritis medicines because patients have ongoing pain from arthritis. But those can be taken actually every 12 hours or every 8 hours, and they're still effective. Same medication, but a different formulation. So I will recommend to patients, hey, if you like acetaminophen as a medication, grab the long-acting form because you're probably going to need it for a couple of days. And this way you're going to have to take it less often. You're going to have a longer effect. You're going to feel better for longer, and you're not going to have to choke down medicine more frequently. For patients who like non-steroidals, it's actually interesting that both ibuprofen and naproxen are in the same chemical class, and they'll probably all reduce fever, but sometimes people don't get adequate pain relief from those. So I will, if a patient's taking those medications and say, they're not helping me, I will prescribe a prescription non-steroidal in a different category. And the Bumbitone is one of my go-to medicines. 500 milligrams twice a day. Actually, I take it myself when I get sick, and it's actually very effective. And again, it's an example of a positive treatment recommendation, giving the patient something. Not that everybody needs a prescription NSAID, but as you're talking through the possibilities and the treatment options for the patient, it's one of the things that can let you give the patient something. And then finally, if you're going through all this explanation and a patient just doesn't seem to get it, just frankly go ahead and ask them, what did you expect today? Let me ask you, what's been your experience in the past? Because I don't feel like I'm giving you what you want. And even ask them what they had hoped for. And then you can address that. And I think once you get to this point is when you might break down and do the safety net antibiotic. Again, these are some examples of the sort of things that I find myself saying over and over again. And these do tend to work. Acknowledging the patient's illness. Say, hey, look, gosh, you look like you feel bad. There are some things that can help. And swing it in a positive way and say, fortunately, you don't need to take an antibiotic with all the side effects associated with it. This actually is my longest running script. If you're the type of person who doesn't like to take an antibiotic unless you absolutely have to, then you really don't have to for this. The body's immune system can fight it. I find that those two in combination kind of work pretty well. And then finally, having a way to explain that even when an antibiotic is necessary, that there's some downside. To have a one sentence that you say, it's not really a cookbook, but it makes it easy to communicate that information. Hey, there's a downside to taking an antibiotic even when you might expect some benefits. There's some other scripting things that are recommended, like using terms like chest colds rather than bronchitis. When you say bronchitis, patients expect an antibiotic. When you say chest cold, they equate it to more of a cold. Using terms like a bronchial viral infection or cough illness might also be helpful, although I find that sometimes those are confusing to patients. I think making it straightforward and easy for them to understand and easy to communicate the necessary information is kind of the goal here. Okay, what's up with this safety net backup delayed prescription? Sounds kind of like a cop-out, but I think this is probably going to be an effective way to ease a transition for both patients and for us. Making a drastic change of never prescribing an antibiotic when it's not needed, probably a good thing. Having patients be satisfied never getting an antibiotic when they don't need it. That's, we may be able to work toward that. But this sounds, I think, is a good transitional idea. And it's not a cop-out. This is evidence-based and shown to be safe and effective, both in terms of getting good treatment outcomes and reducing antibiotic prescriptions. So it does both things at the same time. Really good data with otitis media and acute sinusitis. It is actually the evidence that this works and it's effective and safe to do is the basis for the recommendations by the AAT to wait and observe children who are over 6 months old and have non-severe unilateral otitis media. And then similarly for children who are 2 years of age or older who have any non-severe otitis media, whether it's unilateral or bilateral. And then those time intervals that are in the sinusitis recommendations about waiting 10 days when a patient has moderate symptoms or waiting at least 3 or 4 days if there are severe symptoms. What underlies that is the fact that you can do that. You can wait for the person to delay their antibiotic treatment. So you know that it's safe and effective in those cases. Acute bronchitis, I put a question mark by because it's probably the case that if a patient does not have chronic lung disease, and asthma is not true. Patients who have asthma exacerbations should not get antibiotics unless they have pneumonia. Patients with other chronic lung disease like IPF, bronchiectasis, COPD, when they have certain criteria, do benefit from antibiotics. But acute bronchitis is one of the main reasons that antibiotics are overprescribed. And although it hasn't been studied specifically, there's no antibiotic treatment guideline for acute bronchitis in healthy patients. There's no guideline. But this idea of a delayed prescription, backup prescription, has been studied and there's some reference studies at the end where they group together respiratory tract infections, typically bronchitis, sinusitis, upper respiratory infections, and then they look at outcomes with delayed prescriptions, and there's a reduction in antibiotic use, and there's no worse outcomes. So this is something that we can feel, I think, comfortable if this is not something that you're doing now. Again, the idea is not to continue prescribing like you are, but if you feel like you're overprescribing, to make a dent in that first, and then in those more difficult situations where you feel like you have to do something, to begin to introduce this idea to patients, to say, have you heard about a safety net prescription? And do it as a courtesy to them. That's a good way to spin this. I don't think you should have to take the time to come all the way back if you're not feeling better. So this is a prescription for you that you can take a few days from now. You can post-date it if you want. And then again, to explain it to the patient, you can say that this is a validated approach. This is scientifically sound. And then less wishy-washy when you're doing it. Just an example of some patient education, kind of interesting to look at, nice colors. These can be actually this one has a front and back to it, so this would be something that a patient would hold in his or her hand and be able to read and take home. There are adult and pediatric versions of these that are available from the California Aware Foundation. That was that first URL that I had on the reference on the slide about practice guidelines and patient education tools. Actually, I've had these for a while, and I just went on the website yesterday after I turned in my slides and found that the CDC sponsors this Get Smart campaign, and this is for both clinicians and for patients. But they're rebranding it. The OWL is not on these anymore. Tons of stuff you can download for yourself in terms of how to take care of patients. Tons of information that you can post on the walls of the treatment rooms, or have some handouts for patients, or that you can go over with them in person. Just as you go, you can kind of check off these things yourself as you're verbally going through after you've done your history and exam, to emphasize the fact that an expert says they don't need an antibiotic for the illness that they have. College of Urgent Care Medicine and the Urgent Care Association have a toolkit available at the URL at the bottom. This is some kind of a continually developing document. The first version of it came out this past summer, and there'll be an update soon with even more tools and references in here for links to patient education materials, pointers on communicating with patients and easing the pain of this transition they have to go through. There are sample commitment letters in there, again, making a public commitment about this. There are also some recommendations on a system level. If you're a medical director and need to affect change in your organization, there are some strategies and tools that can be used. And then all of this has an evidence basis. This is not made up. There are, I think, 2.5 pages of references at the end of the toolkit that you can trust, and then as well, dig into more deeply if you have an interest. So I hope at this point, or maybe even before now, that everybody understands that this is not something that we're trying to decide whether or not we do, but we really need to focus on how we're going to do this. We need to understand that it is going to be a trade-off. We need to balance the time involved with explaining to patients a little bit more, and there'll be some bumps in the road and only gradual changes, and patient satisfaction may go down a little bit, but we need to change our expectations and patients' expectations if we want to curb inappropriate prescribing and reduce the rising rate of antimicrobial resistance. Again, having a plan, thinking about this, going into your workday, knowing 1 or 2 or 3 things that you're going to do differently is going to be more helpful than just going in and thinking about doing it on the fly. Using these tools, the patient education tools, or if your own prescribing is a little out of date and needs to be sharpened, getting one of those clinician tools and keeping it at the ready. And then I think the thing that probably is most heartening is that we have done this before. Not necessarily in urgent care, although some urgent cares have access to head CTs or just send patients to the ED for this. These are decreasing. Opioid prescriptions and head CTs and many other things that we thought we could never change are changing. Not overnight, not all at once, not rapidly, but progressively. And we have to look at this the same way. It's as important or more important as these other crises, quote crises that we face. And then finally, I'll close by talking about what I think are the really highest impact tactics. What are the things that are going to give you the most bang for your buck? Again, the foundation is knowing when to prescribe and what to prescribe. As clinicians, that's our main job. I think another high impact area, though, is, again, not to use objective tests indiscriminately, but use them when indicated. A negative test result is very helpful in counting a patient out of an antibiotic. I find a patient can come in with multiple symptoms, like a runny nose and a cough and a sore throat. In that case, it may not be, because the pretest probability is so low, it may not be necessary to do a rapid strep test. But if you think there's enough pretest probability using it and having it a negative result, talks the patient out of the antibiotic for all of their symptoms. scripting is kind of I don't like that term, but I do find myself saying the same thing over and over again. It flows well, and patients understand it, and it packs a lot of information into a few words. And so those are very helpful, I think, having at the ready so that you can begin to change patients' perceptions about what has happened in the past and what needs to happen in the future. Come up with a few positive treatment recommendations. I think, again, you go down the cough and cold aisle in a pharmacy and there are tons of options. Personally, myself, I like liquids, and I tend to buy the two that are packaged together, like the daytime formula and the nighttime formula. And I think the patients, when there's no contraindications, recommending something like that is certainly fine. They'll be doing something that might alleviate their symptoms. In situations where you have that furrowed brow and the patient really isn't getting it, really isn't understanding that they don't need an antibiotic, and although they may have gotten one in the past, it's really not going to be part of your plan for them, openly ask them about what their expectations and hopes are for the visit, and then begin to explore that. And then if you finally, your back's up against the wall, either in situations where you're supposed to wait and give a delayed prescription, or situations where the antibiotic may not be exactly indicated, but you really don't feel like you can get out of it, it's reasonable to use the safety net or backup prescription in those situations. If you get into the habit of doing that, again, not for every prescription, but for the prescriptions that are less necessary, that's, I think, a really good idea for using the transition. So I thank everybody for participating. The additional I referenced a lot of things in the talk itself, but here are some additional references that I think might be useful, particularly in explaining the rationale for delayed antibiotic prescription, as well as ways to talk to patients about this change. Thank you. I'm going to hand it back to Doreen.
Thank you, Joe, for a great discussion. Can you pass the ball to me, please? Oh, you did. Okay.
So in the interest of time, we'll open up the line for take about one or two questions. Doreen, can you give us instructions how to open the lines? And also you can post your questions in the chat as well.
Yes, if you want to ask a question over the phone, please press #6 to unmute your phone, your individual phone, or you can use your mute button.
While we wait for questions, Joe, I have a quick question for you. So for the provider who is concerned or being an outlier, if they change their prescribing habits and their colleagues don't, what do you have to say to that person?
I think this is probably the hardest thing. If we feel like we're committed to change and nobody else is. I think there's a couple ways to go about this. If you're working with a group of clinicians and you have somebody who's a friend of yours who you can talk to about this, to seek that person as an ally. Sometimes when there's more than one person kind of trying to motivate others to change, it's easier. If you're in a system where you have a medical director, then it's important to interact with that person. Go armed with information. You can take the CDC toolkit or the College of Urgent Care Medicine toolkit in with you, that you can express your concern and go about it that way. I think if you're an incredibly influential person, you might be able to do it yourself, but you're going to have a few allies to begin to affect change in others. I think when we're talking with clinicians, a lot of us like to see data, so if you can go into an EMR and find out prescribing rates for, look up the diagnoses for patients that don't need antibiotics, find out prescribing rates for that, again, to go to people and say, look, you're one of the highest antibiotic prescribers in the group, you can target information and affect change a little bit better that way versus just telling everybody, hey, we're doing this wrong and we need to change. So those are some strategies for that.
Thank you, Joe. So I have a question on INSCA. question is, any experience with obtaining antibiotic prescription numbers from a centralized source and giving these numbers to the prescribers?
I think that may be what.
I'm not sure if it's referring to kind of like a scorecard or something of that sort. Individualized.
Yes.
Scorecard.
Well, I think I've worked at a couple of urgent cares where it was probably about 8 or 9 years ago, but where the rates of antibiotic prescription were reviewed. They were posted, so everybody knew how they stood relative to other people. There's actually some evidence in terms of a centralized source. I mean, I think you would probably, have to look at your electronic medical record. I think payers keep track of this sort of thing, like the insurance companies do. But because there are multiple payers for the patients that we see, I don't think you'd be able to put together a bunch of data on it. I think, using your EMR would be the way to get that information. And there's evidence that if you do nothing more than show people what they're doing, and people get a sense that, well, I'm prescribing a lot more than everybody else, that can actually affect some change in and of itself. Show people data, explain the data to them, and you can get some changes there. So there's study evidence that the experience is that it works, and then I've had some personal experience where it's been posted, but we never looked into whether it changed. It was just before the antibiotic stewardship efforts and the importance of this was being emphasized.
All right. So the individual just clarified. So he is thinking about information coming from payers, whether you receive any antibiotic prescribing numbers from payers that you have shared with prescribers.
Yes, I have not, but I do know that it's tracked. Actually, I was talking with one of the medical directors last month at the New England Regional Urgent Care Association conference. She's a quality medical director for Excellus, which is New York State Blue Cross Blue Shield, and she said this is something that they do, and that they track it themselves, and then they give feedback to providers. But that's just one payer, so you won't get comprehensive information because, I think most urgent cares may have 20 different payers. But payers do track it, and it may be possible to get that information from them. I think the best way would be just to mine your own electronic medical record, though. That it's actually probably the easiest thing to do, and it's going to be the most comprehensive because you can get data on every patient that was seen at a practice.
Yes, I
think the value of payer data may be if a clinician works at multiple locations, then we may get a sense of what the prescribing is in total everywhere. I think that whether that would be useful or not, I don't know. You'd have to decide for your setting and what your goal is.
Right.
I saw something about for symptomatic relief, what my go-to medicine is. It's nabumetone. It's in a different, so it's Relifen is the brand name, but it's generic nabumetone. And the adult dose is 500 milligrams twice a day. It has a long half-life, so it doesn't have to be taken very often. And it tends to be effective. And it's an alternative. It gives you the ability to prescribe something or do something for a patient rather than, recommending it over the counter. If you're getting a sense that they were using it over the counter and it's not helping, then it's an alternative. And it's a non-steroidal anti-inflammatory.
All right, Joe. Thank you very much. In the interest of time,
right.
On your screen you will find how to reach out. These are folks, my colleagues that I work with, and then New England QIN-QIO. These are the emails. Based on your state, you can contact any of these individuals if you have any questions. Some of the resources, we have them, we can share with you. And if you're an urgent care on the line, please, we would like to reach out, get in touch with you and support you in your antibiotic stewardship work. Right. And these are colleagues of ours that are part of the QIN-QIO in various states. If you are an urgent care person, please identify based on your state. These are people that you can reach out to as well. And we'll be sharing this. This comes with a slide, so you will have this information to reach out to these folks as well. If your state wasn't highlighted, this is where to go, where based on your state, it will show you which QIN-QIO serves your area, and you can reach out to them as well. And for the QIN-QIOs that are looking to reach out to urgent care centers, this is the contact Carla Jemison. You can reach out to her, and she'll be able to connect you with urgent care in your region. So, and this is the code for pharmacists seeking CE. The code is urgent care. I will now hand over to Doreen to close that.
Okay, just a few last announcements. The Learning Center is our virtual learning system which hosts free courses for all healthcare settings. Our goal is to educate providers and help them improve the quality, efficiency, and value of healthcare. Create your account today by visiting www.learningforquality.org, and the 4 is the number 4, and find your registration code for your healthcare setting. If you have any questions about the Learning Center, you can send an email to learning@healthcentric.advisors.org for assistance. We are on social media. Please follow us on Facebook, LinkedIn, and Twitter for the latest resources, webinars, and other offerings from New England QIN-QIO. Okay, so when you close out of this webinar, an evaluation will automatically appear. We appreciate you completing that evaluation. The link to the evaluation was posted in chat. CUCM participants who are interested in CME credit must complete this evaluation and email education@ucaoa.org to receive CME credit. That was also posted in chat. If you don't have time to complete the evaluation right now, or you're currently sharing a computer with someone else, you'll receive an email tomorrow containing a link to that evaluation. As we mentioned at the beginning of the webinar, the PowerPoint presentation is currently posted on our website, and the link was posted in chat. Within the next few business days, a recording and transcript will also be added to our webpage. The links for this will also be included in tomorrow's email. Thank you again for this great presentation, and to everyone for attending. Have a wonderful day.
Thanks, everyone. Bye-bye.
Thank you. Thank you.
Bye, Joe.